Hello and welcome to DM Neurology Made Easy. This is the 15th episode of Fine Neurophilia Quick Revision series. Let's see the demyelination part 2 video.
So we have discussed regarding the paroxysmal symptoms. These could be Lermet symptom, which causes tonic contraction of face, trunk, and sensory disturbance in multiple sclerosis. These can be distinguished by, these are difficult to distinguish because these could mimic TA, epileptic activity, etc., etc. And they actually subside by themselves. So how do you differentiate it? So it is based, if you have high index of suspicion that it is something else, we have to definitely go for an EEG. And if in case of this kind of symptoms, the EEG will be normal. So all of them have answered it correctly. This is taken from Harrison. So nothing. So Lermet symptom. So more about Lermet symptom. It is otherwise called barber chair sign. So when the barber tries to flex your head for proper cutting of the hair, electric shock-like sensation goes down the spine. This is called barber chair sign. So it is not a pathognomonic sign of MS. It is seen in n number of conditions. And you should have an idea that Lermet symptom is not seen in MS alone. It is not seen in even in vitamin B12 deficiency, cervical spondylosis, etc., etc. Can be seen in other symptoms, even like nitric oxide toxicity, etc. Two variants of Lermet phenomenon is reverse Lermet phenomenon, that is neck extension. So neck flexion causing electric shock-like sensation is called Lermet phenomenon. Reverse Lermet phenomenon is neck extension causing this kind of symptom. So that is usually seen in cervical spondylopathy. And another variant is called inverse Lermet phenomenon. Usually we know that this Lermet phenomenon goes down the spine. If it moves up the spine, it moves to the head, then it is called inverse Lermet phenomenon, and is usually seen in case of, it is very rare, and is found, it is seen in case of a nitric oxide inhalation. So now we have discussed regarding MS pathophysiology, pathology, clinical findings, etc. So if MS occurs within the spine, if it extends to more than 3 segments, then you think of NMO, that is neuromyelitis optica. If it occurs within one segment and it is usually, it will be towards one side, that is laterality would be there, then the presentation would be like a Brown-Sequard syndrome. But the patient will most likely have symptoms like a band-like sensation over that corresponding cervical area or cervical or the thoracic area. So that band-like sensation in MS is termed by something called as MS hug, multiple sclerosis hug, MS hug. So that is a term given in Bradley. The risk of MS, if a sibling has MS is not common in our part of country because we are in a tropical climate. MS is more in the higher latitudes, that is in the temperate regions, and it is more common in females. And the risk of developing MS, one table is there in Harrison. There is high probability that this would be asked, and this has been asked previously also. If you study, if you know this table only, you will be able to answer. In that table, at least remember the fact that parents will be having a 50%. Monozygotic twins, at least remember 3 of them. Monozygotic twins, 3, parents 50, siblings 25. That is the only 3 things I remember. So at least learn 3. I won't ask you to study everything because it's very difficult. So these 3 study for yourself. So identical twins 3, 1 in 3, siblings 1 in 25, parents 50. At least that you should remember from this table from Harrison. Which is the most common type of MS? So there was a fourth variety, that is a progressive relapsing type of MS. Was there before 2013. But after 2013, that was included under primary progressive type of MS, and it was termed as primary progressive type of MS, active or not active. So before that, there were 4 types. Now there is only 3 types. So 90% of MS is relapsing remitting type, which we commonly see. And this was the previous classification. Now this is from Harrison, that is RRMS, PPMS, and the most common one is the RRMS. The least one is the primary progressive. Read the question before answering. That is the very important thing. In the Harrison, they have clearly given the most common risk factor allele for MS is HLA-DRB1 1501. But in Bradley, they have given one more point that HLA-02, HLA-A02 is actually protective for MS. So that point I wanted to you all to know. So the first one is pretty simple for you. So that is this gene allele is protective. These three gene alleles are actually protective for MS, are very high risk factor for MS. And this HLA-A02 is the only protective MS HLA allele. So this is from Bradley, the latest edition of Bradley, which is incorrect. So you must have read the etiopathogenesis of that etiology of MS. So many viruses are implicated, like CMV, HHV6, EBV, chlamydia, etc. And of which questions could be asked multiple ways. Which is the most common virus implicated in case of MS? What are the other factors, etc., etc. So the question is, which one is incorrect? Seroprevalence of Epstein-Barr virus when checked in the MS patient was found to be 99%. But the thing is that in case of normal controls also, it's very high. That is another thing. But seroprevalence in Epstein-Barr MS patients for Epstein-Barr virus was 99%. And SOLAR trial was a trial to look into the vitamin D efficacy in case of MS, whether the patient improved or not, but it failed. So some trials showed that vitamin D is beneficial, but the SOLAR trial is one of the largest trials which showed that there is no efficacy of vitamin D. And smoking increases definitely risk. And sun protection factor blocks 94% of incoming UVB. So this is one of the largest trials which didn't show efficacy of, they didn't improve the relapse rate or disease-free activity in case of vitamin D supplementation in case of MS patients. Which of the following factors show evidence of risk reduction in MS? High coffee consumption has neuroprotective and anti-inflammatory effect. So in this, obesity is definitely causing high risk of multiple sclerosis. And you should know a proper night's sleep. If a patient or any normal person is getting a proper night's sleep, then this melatonin is found to be having a protective effect on MS. So if in case of shift workers, this melatonin activity will be deranged and the person will be having high risk for multiple sclerosis. Read and answer the question. RRMS, that is relapsing remittive MS, which is the most common one, has found to be having this latitude, that is temperate tropical difference. That is, in temperate countries it is more, tropical it is less. And also one more thing is that in females to male ratio it is actually 3:1, 2 or 3:1. And one more thing about this primary progressive MS. This has a steady decline in case of MS. And this in every place which we checked, which they checked, it was the ratio in female to male ratio was actually 1:1. So this was from Bradley, 8th edition. So MS in pregnancy is actually a very important thing and repeatedly asked question. So this is a repeat question. So that I suppose everybody would be knowing the answer. The MS relapse risk in pregnancy is maximum during which one of the following time frame? So most of them have answered it as 3 months postpartum, and that is the right answer. If you take this 9 months before delivery and 3 months postpartum, that is usually considered the time of pregnancy. The MS relapse risk is actually normal. There is no much change. Overall risk is normal. But if you segment this into first, second, and third, the most increased risk, higher risk is during the 3 months postpartum. And the way reduced risk is, the least risk is during the third trimester. So that is an important point you have to learn. This could be asked in either ways in case of MCQs. So as we have seen, MS diagnosis needs high index of suspicion, and we have seen the symptomatology for MS. And the criteria actually is getting revised. First criteria came in 1965, that is the Schumacher criteria. Then in 2001 came the McDonald criteria. All the criteria has got the basic backbone. That is, one is the main symptomatology, how it presents. Then the evidence, that is the evidence of CNS involvement. Then all must have heard dissemination in space, dissemination in time, and there should be no other causes of MS like vasculitis, other NMO, MOG, sarcoid, other infectious diseases, etc. So these are the main criteria. So if you have in your mind, these are the main backbone of the criteria, and then study, it will be easy for you. Of which dissemination in space and dissemination in time are very important. No. So the three typical syndromes of MS usually are, as we have discussed, is optic neuritis, brainstem syndromes, and transverse myelitis. Of optic neuritis, we have discussed in large. Then brainstem syndromes will involve the usual ones, that is the INO, bilateral INO, the cerebellar symptoms, nystagmus, etc. Then the transverse myelitis, which will be limited to less than 3 seconds. So as we know, as I told you, 1965, the Schumacher criteria, 2001, the McDonald's criteria. In 2010 came the Polman modification of the McDonald criteria. And latest, and what we follow now is the 2017 revision of the McDonald criteria. So the lesions where we look for MS is in certain regions. So if you have multiple lesions in the brain, if the whole brain is in having multiple MS lesion, even then we classify the lesions as in specific areas. If that areas have MS, then we categorize it as MS specific lesions. So which one of the following area was newly added to the 2017 revision of the McDonald criteria? So before that, what were the previous lesions, we have to know. So if you are aware of the previous areas, you will be able to answer, but most of them have answered it as cortical. That is the right answer here. Because you know the previous areas in MS, yes, they are the juxtacortical. So you must have heard these juxtacortical, periventricular, infratentorial, spinal, etc. Spinal, there is no confusion. Infratentorial means just below the tentorium. So it will include all those below the tentorium, including the cerebellar. And periventricular needs no further explanation. That includes the Dawson's fingers. So questions on Dawson's finger, why it occurs, perivenular, cuffing, etc., will be asked. And what is this juxtacortical? And what is the difference between juxtacortical and cortical? Just for your knowledge, juxtacortical means it is just near to the cortex, abutting the cortex. It is otherwise called subcortical U fibers. This way you will hear it mostly in case of pediatric neurology and also in adult neurology, but this is the juxtacortical region. So this is the cortex, which is actually gray matter, not white matter. So we are talking about white matter lesion. So this one is actually the juxtacortical lesion. And what is cortical lesion? So MS being a white matter disease, will be having cortical lesions. And these cortical lesions in MS are difficult, actually are difficult to find in case of with a normal MRI, and we need a high expert interpretation and high Tesla MRI to detect cortical lesions in case of MS lesions. So juxtacortical, periventricular, infratentorial, and spinal, of which we don't consider cortical as separate. Juxtacortical or cortical is considered separate. So still there are 4 areas in brains regions considered specific as MS specific regions, of which the extracortical and cortical are considered together. And dissemination in space is very important, because we want to brand it as MS. Otherwise, a patient coming with a single disease or a multiple episodes with a history of multiple varied symptoms, we have to brand it as MS. So for that, the lesion should be having dissemination in space, which is actually 2 lesions, 2 MS typical CNS lesions, that is 2 out of 4 should be there. So remember this, 2 out of 4. And dissemination is time is based on the contrast enhancing and non-contrast enhancing lesion in a single MRI. But if you are getting a follow-up MRI, we have to have two different lesions, or you have to wait for a second attack if that is for a clinical dissemination in time. So this is the 2017 modification. So what this is because of lack of time, you can read through. You have to. I think it's better to know the few points that this oligoclonal bands came into being. So oligoclonal bands have come is important criteria. So any patient with MS, if you are confused with the diagnosis, don't wait. Go for a CSF oligoclonal band testing. That will help in the removing the confusion, especially in case of first attack and the patient is we are doubting that the patient is having a clinically isolated syndrome, which I'll discuss further. And cortical lesions, as I told. Okay, so it's very easy. If you see this table, Bradley has also one more table. I think I have added. Yes, same. If you can see, but it's big cram. You can follow this table. This is a patient presenting with MS-like features, and MRI shows a periventricular hyperintensity with no other evidence of MS. So what will you call it? So any lesion, any patient with first attack of MS, MS-like symptoms, without any MS criteria fulfilling radiological findings, we call it as a clinically isolated syndrome rather than a radiologically isolated syndrome. And a patient with migraine was evaluated with MRI brain. So in a patient was having continuous chronic migraine, and the physician had thought of looking into any causes of this secondary causes of migraine. And on imaging, he was found to have this kind of findings. That is typical of MS. So what do you call this? So you can see this. These are Dawson's fingers, infratentorial lesions, spinal lesions, contrast enhancing lesions. Everything is there. Yes, but the patient has just got migraine, typical MS attack, and it's just a migraine he was continuously having, and it has nothing to do with MS. And on incidentally, we got the finding of a radiological finding of MS. So this is actually a radiologically isolated syndrome. If the MS lesions are typical of MS and fulfills this criteria of McDonald's, etc., radiological wise, there is a 34% chance that the patient will, after 5 years, that is within 5 years, will have MS-like symptoms. So that is one more important clue finding. So we talked in large about CSF oligoclonal bands, which have become a star with the latest 2017 guidelines. And one more point I would like to say that even though optic neuritis is the most common finding in multiple sclerosis, it has not been added in this MS specific lesions in MRI, because that you have juxtacortical, infratentorial, spinal, cortical, everything is there. But even then, this anterior visual pathway is not included even now as a MS specific lesion to be accounted in while considering the dissemination in space. So if a patient with optic neuritis have a lesion within the optic nerve, still we don't consider it as a one of the criteria, even one of the criteria. He needs to have either more than two lesions, either in the juxtacortical, infratemporal, spinal, or other areas to fulfill the criteria of MS. That is one more point you should keep in mind. CSF oligoclonal bands are found in more than 75% of patients. That is true only. And OCBs may be absent in the initial phase of MS and will come, actually it increases with time. That is the important point. It doesn't decrease with time, it increases with time. And if the CSF shows more than 75 cells, or if protein is elevated, we have to have a high index of suspicion whether it's not MS or it's any other disease like inflammatory disease or infectious disease. So that is the important point. This question was taken from Harrison. So while reading Harrison, have this MCQ orientation of answering the questions. So this was what I was talking now. It is in Harrison, it has given more than 75%. So this is from Bradley, which shows that the OCB positivity is actually 85 to 95%, which is the most likely diagnosis from this MRI. What do you think is the most likely diagnosis? It's actually to one side, right? So it's actually lateral. So you see again NMO is the same table. It is NMO, MOG, etc. will be more of to one more bilateral. MS is kind of unilateral. And as I told you, vitamin B12 will be having most posterior column affection, and anterior spinal artery syndrome will have the typical owl eye sign. If you see here, anterior spinal artery will have the owl eye sign, and it is not typical for anterior spinal artery occlusion. It can be seen in cervical spondylitis, viral myelitis. So multiple NMO, it will be bilateral. Vitamin B12 deficiency, it will be posterior and posterolateral. Multiple sclerosis, it will be towards the one side. So it will, if you consider midline, this will be most likely one side. So which among the following investigation has the highest sensitivity for multiple sclerosis? Which of the following investigation has highest sensitivity for multiple sclerosis? My MS is actually white matter tract lesion, and all these evoked potentials look into the conduction along these white matter tracts. That is, brainstem evoked potential is brainstem auditory evoked potential looks into the auditory pathway. SSAP along the tracks, long tracts. VEP along the visual pathway, and MRI, as you know. So what do you think? MRI is the most common, most sensitive among this test. So I have ordered the slides according to their sensitivity only. The most sensitive is MRI, followed by VEP, visual evoked potential, followed by SSEP, followed by BARA. Visual evoked potential is evoked potential. We look into the P100 latency. So if there is loss, there is demyelination, there will be prolongation of the P100 latency. So P100 itself says that the normal latency is usually 100. If it is prolonged more than 10 or 10 times, more than 10, that is P100 becomes P100, 110 or 120, then it shows that it is prolonged. Then it suggests that patient has this MS or optic neuritis. Which among the following is rather benign? It doesn't show that it is benign, but out of which is the benign demyelination? So these are the types, other variants of MS. Read the question and answer rather than jumping into answering. Marburg's variant is actually a highly acute variant of MS. If not treated properly, it is highly fatal. Ballot's concentric sclerosis and Schilder's variant is another name for Marburg's, which was previously used. Hence, I just put the name. So Ballot's is the one which you need to. So this is the Marburg's variant, and this is the Ballot's concentric sclerosis. These alternating rings are due to demyelination and remyelination occurring, and it could be self-resolving. So I think this was an introduction to multiple sclerosis. Further, very important topic is regarding the DMR, the disease-modifying drugs in multiple sclerosis, their side effects, and the latest ones, that is NMO, MOB. And also we'll touch upon the pediatric demyelinating disorders in the next class. Hope this video helps you read these Harrison as well as Bradley.